I did what I said I would never do. I made whole scale changes like minutes before the training. So we'll see what happens. I'm just going to step away for just a minute. I'll be right back.
All right.
Okay, we're going to get started in just a few minutes. I am recording, so please keep the swearing to a minimum. We have about 18 of our 24 people. Hi, Adrian. I'm watching the participant list. It's like watching popcorn. You never know when it's going to stop.
Yeah.
Or is it going to burn?
That's true, yeah.
Is it going to burn before you?
It's tricky, isn't it? That perfect bag of microwave popcorn. Tom, do we have a breakout today?
Yes.
Okay.
Yeah. And now I'm an expert. So.
Wonderful.
All right. I'm going to go ahead and get started. I have not changed. I'm still Tom Bartholomew from Rutgers. And again, and as always, thank you for being volunteered to come to this. And I hope you're getting something out of it. This is our last day together on these topics of clinical supervision. And today, I think you're in for, hopefully, you'll find this as interesting as I find it. But I'm going to be focusing on this concept of implementation science and how it relates to our clinical supervision project and the larger clinical formulary project. Let me turn my, all right. So this has been the training agenda. We covered 4 topics of the 5, and here's our last one, the implementation. And these have been recorded, and they will be available on the Rutgers website. Dawn, if you would, could you once again post the link? Great.
Or
I have this queued up to send these materials to you. So you're going to, in addition to the PowerPoint slides, you're going to get these 5 documents. The first one is a fidelity scale for clinical supervision that I developed with a colleague, Joe Berkman. And it's never been validated, but it covers a lot of what this presentation talks about. And it just looks at, is the supervision being restorative and formative and normative? Is it meeting regularly? And real basic stuff. So you're welcome to check that out. I will be showing you a much simpler version later in this training that we'll use for this project. So this is the full Monty, you might say. The other thing I said I would send you, which I will, and it's coming, it's that table, the best practices in audit and feedback. Because as a clinical supervisor, that's one of your main tools, is doing really good audit and feedback. So you'll have that table available. I'm also sending you a generic clinical supervision contract, because it's really popular in the literature, much less popular in our state hospital system, but at least you'll know about it, have a version of it. Number 4 is a proprietary clinical supervision scale, and it's purported to be the most utilized scale to determine the benefits of clinical supervision, the self-reported benefits of clinical supervision. And we've used it numerous times, and we paid for it. I think we paid $3,200, believe it or not, to use this scale. And it's been used internationally and normed internationally. So I think a score of 32 or above is associated with positive outcomes, and a score below that is not associated with positive outcomes. It's not associated with negative ones either. But. Okay. Dawn, can you mute folks?
Yep, I got it.
All right, so that's called the MCSS 26, which is the Manchester Clinical Supervision Scale, and it's called that because it was developed in Manchester, England. And then the last thing I'm going to send you is a generic agenda for clinical supervision of the type I've been presenting on, right? So that it's highly restorative, and it just has some kind of breaks it out of, like, how you can go through our agenda. Hey guys,
it's not allowing me to mute people. I'm not sure why.
Hey guys, if unless you're talking, please mute. I see you, Shmurdy.
There's quite a few that aren't muted, but I can't. It's not allowing me to mute them.
Oh, it's allowing me. Look at that. I'm special. All right, I got him. Oh, I almost muted myself. That would be horrible. All right. So that generic agenda will be coming your way too. And I recognize it's a lot of materials, but if you're interested in clinical supervision and you're serious about it, it's worth knowing what's out there and what's available. So I confess that prior to this training, I made whole-scale changes to this presentation, which you should never do, but I did it. And what I did is I added slides from a presentation I did for a different, for another contract that Rutgers has with Washington State mental health system. And so and this is really a rhetorical question, but I'm wondering if you have seen failed change efforts, and meaning if it has the hospital you work for or the system of hospitals attempted to change something which has failed. And let's make it less than rhetorical. Just put it in the chat if you have examples of things, concrete examples of things that have failed. Do you have good examples? I think I could fill up the chat. I mean, so much of what I do has to do with efforts to change things, and we've experienced some significant failures.
But we don't fail. We fail forward.
Oh yes, yeah. There is truth to that too. Sometimes I think we just fail.
Oh, sometimes we do. Let's see. I don't see anything in the chat yet.
I think they're overwhelmed. Like, where do I begin? I'm thinking of like dynamic risk assessment. I think in some ways failed, and it depends how you define it, right? Depends how you define failure.
Maybe it also depends on what your particular expectations were of the project.
Exactly. Yeah. All right. So feel free to chime in on that. I'm suspecting that you probably have seen them as well as I have. So I'm going to be talking a bit about this thing called implementation science. And implementation science has to do with how do you get organizations or clinicians even to adopt best practices, including the best practice interventions, but also policies and clinical behaviors into the public health setting. One example I believe I used coming up is hand washing, which seems so straightforward in a medical hospital. And you would think, well, that's a slam dunk. Everybody would agree that's incredibly important. Not hand washing. No hand washing is associated with hospital-acquired disease. And so it should be really straightforward. As we'll see, that's not always the case. So some terms in this new science of implementation are dissemination and implementation. And honestly, I see them as very, very similar. The difference appears to be that dissemination is a broader attempt to like spread illness management and recovery or hand washing or vaccination or whatever it is nationally or internationally, whereas implementation is a more specific attempt to put the practice to use within a given setting. Some other terms in the literature, and particularly in Europe and Canada, they use knowledge exchange or knowledge transfer to mean the same thing. So why is implementation science important? I mentioned in the first day of this series, the PORT studies, the patient outcome research team studies, where they did massive literature reviews looking at what is the best evidence for the kind of work we do, like what helps people recover, what helps people reduce their symptoms, what helps reduce anxiety and depression, all that. And what they found was that the science is stronger and stronger every year. It gets better and better, an understanding of best practices and evidence-based practices. But so many programs nationally and internationally are not delivering those interventions in ways where you would likely see the outcomes that are possible. And they call this the science to practice gap, and it's very prevalent. And it's at our hospitals, but it's really everywhere. It's in every hospital, and I shouldn't say it's at every hospital. There are cutting edge programs all over the place. But generally speaking, patients are not receiving evidence-based practices at the rate we would want them to. I tried to brainstorm, why does this gap occur? And on day one, we talked about train and pray strategies, which is the idea of using our training departments at the hospital, say, to just tell people what's out there and the evidence, show them the evidence. But as I mentioned on day one, that it just is ineffective. It doesn't have the effect of changing clinical behaviors the way we want. The other thing I've seen personally is oftentimes leadership thinks we're doing some strategy, whether it be evidence-based or not. I recall Teresa McQuaid years ago at Trenton Psychiatric Hospital telling me that we're using, that nurse-directed care is happening throughout the hospital. But I was in the hospital and I was pretty sure that that was not true. And it may have been happening here, idiosyncratically here and there, but it certainly was not happening at the level she thought, or in the ways she thought. And then it may be that we're just not getting the word out, that that people are unaware that there are strategies to promote recovery from schizophrenia, for example, or even if people know it, maybe they lack the skills. Motivational interviewing is really difficult to do well. I certainly struggle with it, like most people. It could be resources. It could be we have our hands full just triage at the hospital. People are coming in, we band-aid what we can, and we have a lot of staff, but we really don't have maybe the training. Those staff may not have the skill set, or I guess that's skills, not resources. Well, maybe the need so outstrips the resources. That could be possible. Maybe there's a lack of interest. Maybe people working in our state system are really there to collect a paycheck, and they're not particularly interested in struggling through complex clinical interventions. And then there's this last one. Maybe programs don't work in the real world. And this is a really important question in the science of implementation. And the question is, say we try to do illness management and recovery, or any of the 8 programs in the clinical formulary, and we measure it and we find out it's not producing good outcomes. It doesn't seem to be working, right? And so the question is it that the program doesn't work with our people? Maybe our people are different, they're sicker or whatever. Or did we not implement it properly? Right? And this question is at the center of implementation science, trying to answer this question. And as you'll hear later, the danger here is knowing whether we implemented it properly. We can't overburden staff to determine if they're doing the project effectively, right? We have to recognize that they're super time pressured. They have a whole life outside of what we're trying to do, work life as well. So I hope I'm making that clear. I feel like I'm kind of tripping over myself, but this will be the struggle we're trying to address with the clinical formulary. So example then is, say you implement a hand washing program in a general hospital and you don't see infections go down, right? So the question is, well, are infections not coming from dirty hands? Maybe they're coming from somewhere else. Or are people not actually washing their hands the way we want? So this is here again a nerd alert. So in my graduate program, I learned these terms called internal and external validity. And if you remember my description of that, reliability is like you get on the scale, the bathroom scale, you get off, you get on, you get off, you get on, and it repeats. So reliability is repeating. So if something's reliable, it repeats, it'll happen again. If something is valid, there's truthiness about it. There's truth to your assessment of the thing. So in university settings, when we study something, we control it the best we can. So we pick folks just with schizophrenia and no other comorbid condition, hopefully, right? And we just want to see, does it help with people with schizophrenia? And if we find that the program does, say we can reduce the symptoms of schizophrenia with this approach, this treatment, we call that internal validity, meaning that the intervention, we call it the IV, what does IV mean? Independent variable caused a change in the dependent variable. The pill caused a change in the weight. The pill reduced depression. The thing we did had the effect that we wanted. We call that internal validity. But the bigger question is external validity. Does the pill cause the change in the real world? Like if we do that program at Trenton Psych or at Greystone or at Ancora and Klein, do you see the same effect? And you don't always see the same effect for a variety of reasons, which fill up articles about implementation science, right? That's the challenge is external validity. That is it true in the real world outside of the university setting or the research setting? I don't know about you, but I find that interesting and important. So this science has really taken off, and some of the big hitters in the field of psych rehab and rehabilitation and medical health have been writing about this. And it's because the implementation failure rate in the literature is so high. I was joking about failures in the hospital system, but nationally, they're as high as 73%. In fact, there was this large meta-analysis, I think it's Bridgeforth at the bottom, 2000, where he replicated a study done in the 60s, and he found that in the 60s, the failure rate was 73%, and it's still 73%, and some studies go as high as 93%. Other studies, of course, it depends on a lot of variables, right? Sometimes hand-washing efforts really, really help because hand washing actually does work. Who knew? All right. So I watched a presentation from one of the leaders in the field of implementation science, and she said the majority of change efforts fail to meet their objective, and 50% fail to do anything. So just like what Dawn said, sometimes we'll do something in the hospital and it'll have an effect, and maybe even maybe a positive effect, but it may not have the effect, the entire effect we're looking for, like the reduction in violence we had hoped we would see if we use dynamic risk assessment like the Brosette and the DASA, if you've heard of them. So this is a very good reason to take implementation science quite seriously and see what it has to offer us. So this slide is just bragging. I know. So my team and I have been working in this area. We didn't know it was implementation science, but so we published quite a bit. And if you see here at the very bottom, Bartholomew Kensler, that's the new CEO of Anne Klein Forensic Hospital. He and I did a study on external validity of IMR, because now you know what that means, right? All right, so I'm sure you'll be looking those up this evening. Okay, so one of the things as I started to, and I've only been doing this about a year, like reading in this area, but they make a distinction between implementation outcomes and clinical outcomes. And I realize in retrospect that the hospitals often focus almost exclusively on what I would call clinical outcomes. Did violence go down? Does depression go down? Does anxiety go down? Whatever your target is. And we focus very little on implementation outcomes. And I'll tell you a bit what the field tells us about these two differences, the difference in implementation outcomes and clinical outcomes. So implementation outcomes differs from a focus on reducing depression, reducing anxiety, and looks at things like readiness to implement. So an implementation outcome is how ready is an organization, how ready is a staff person to do a given thing, to implement, say, illness management recovery or dynamic risk assessment or DBT or CBT, all the acronyms. This was one of the most helpful distinctions I saw. So Bernard Weiner, he broke it into two types of readiness. He said there's structural readiness and psychological readiness. And he said that structural readiness is, do you structurally have what you need? Do you have the space, the rooms? Do you have the materials? Do you have the time? Do you have the people? Do you have the training? Right? All of these kind of things that if you don't have those, it'll squish you. And of course, right now with COVID, our structural readiness is in the toilet. Like there's a lot of space in these hospitals. It's different at each site, but if you can't commingle, the readiness goes down, certainly, right? And then he talked about psychological readiness. Are the staff ready to do this? Are they burnt out? Are they overwhelmed? Do they have 15 other projects? Are they underpaid, which maybe would affect their readiness? And so I found this very, very helpful to think this way. But he goes on to say that if the staff know that we don't have structural readiness, if you know there's no place to run this group confidentially and there's no way to provide this amount of programming if you can't commingle, that will affect their psychological readiness. In other words, these are not separate things. They overlap in important ways. Let me just go through and see, mute. All right. So I thought that was really, really helpful. At the most basic level, this idea of structural readiness and psychological readiness, I think can serve us well if we ask questions about these things. One of the leaders, and she wrote a seminal article in 2011, and her name is Enola Proctor. And I find the name Enola just beautiful, so I think she's awesome. But she was one of the first people to talk about this idea of implementation outcomes. And she said there are 8 of them that she calls implementation outcomes. And she says that these 8 are different. All of them are very different things. I find them they seem to overlap a lot when I read them. And at least this is my little baby explanation of them. So maybe I don't completely understand all of them. But so she said, the first implementation outcome is, do the people that are going to do it, the stakeholders for the project, that would be you guys and me and Chris Morrison and the CEOs, do they think that the project is acceptable? Or she used the term agreeable. Now, it's a little blurry, but does this make sense? Is this something you would be willing to do? Do you agree it makes sense to do it? Do people have the intention to use it? So maybe you're sitting in this training and you're like, yeah, I hope this goes away. I'll never hear about it again. Is it appropriate? Does the evidence-based practice seem to fit your need? Like, say we're trying to address what used to be called multiple personality disorder, dissociative identity disorder. And it's like, how many people have that? So, maybe it's not a good fit. Maybe we should be doing something else. And then this one, of course, has the structural piece. Is it possible in our site? Is it feasible? Like, yeah, it's a great idea to do it, but there's no way in hell we're going to pull this off. Like, we failed at much easier things than this. And and then, of course, cost is literally the cost. Like, can we afford this? Or, like DBT is very expensive. It requires, a lot of training, a lot of consultant time, and that kind of thing. Then 6 is one I think most of us are kind of familiar with. It's this idea of fidelity. It means, are we doing the program the way it's intended? And how do we know that, right? So that's an implementation outcome. And then you can kind of change all of these depending on what you do. You could try to reduce the cost. You could try to increase the feasibility. And this is exactly what she was talking about, is we're going to try to measure some of these and try to address them. Number 7 is how much of the program is going on in the institution or the system. So I've seen both extremes where there's either way too much IMR happening, or there's one group happening in a hospital of 500 people, and and many more could benefit from it. So we want to get that level right, the penetration level right. And lastly, and this kind of happens after we get going, is it sustainable? And did we sustain this project at a high quality over time? I know that's a lot, but so hopefully you're getting the idea of how these outcomes differ from clinical outcomes. They are the things Chris Morrison would call these leading indicators, that if we get this stuff right, there's a much better chance we're going to get the clinical outcomes to be positive. Any questions out there? Any questions? Any rotten fruit? Is anyone still awake?
I am, but there are no questions.
All right. But you're paid to be awake, so.
Not enough. Just kidding.
Maybe that was a bit of a stretch. I don't know. All right. So let's just break this down a little bit and look at the hand washing example. That the clinical outcome in this case is that we want to reduce infections. And we're looking at a medical hospital. We could actually be even looking at our psychiatric hospital, but for the purposes of the example, this is a medical hospital. So what are the structural readiness outcomes? What are the things that we would need to do to be ready to do this hand washing intervention? What do you guys think? Put it in the chat or turn on your mic if you can. What are the things you would need to do a hand washing intervention to prevent infection in a general hospital? See, somebody popped in. Look at that. Melissa, you get a gold star.
Working sinks. I love that.
I know, right?
I love that she was that specific.
Yeah. No, not just sinks. That's right.
I had a sink in my office, so I understand, and a drain in the floor. So yeah.
But I don't know if Melissa intended that, but that's awesome, because we all know that there are sinks in our hospitals that don't work, right? And so that's not going to happen. Yeah, oh, she did know. Yeah, there you go. That's good. Yeah, so but you're dead on, right? So the hospital administration could be thinking, all right, so everybody's got to, wash their hands, wash their hands out. That's the thing. They put up posters, they do all this stuff, but they don't have working, and look at it, they don't have paper towels. They don't have the gel dispensers. Need to keep up with good hygiene, absolutely. Set up goals, pre-implementation survey. Oh my God.
Yes.
B. Nelson, you can work for Rutgers now, because that's exactly how where we're headed. You pass. You're good. You can go. Okay. So, but you can see how it's possible that hospital administrators will develop an intervention and not address these things. We just assume there's paper towels, just assume that sinks work. We have sinks in all the rooms, so I think we're good to go. Let's go. And all right, I think you did really well on that. So what are some of the psychological readiness outcomes? So those are the structural. What are the psychological readiness outcomes? Harder for this in this case. So I'll tell you a brief story while you're entering the chat and putting in what you think the psychological readiness are. So my mother, before she passed, was in the emergency room. She had fainted and ended up getting a pacemaker. But a nurse came in to do paperwork with her while she was in the bed in the emergency room. And I was sitting next to the nurse, and I noticed that the nurse was licking her fingers in between each page of the assessment. And I said, "Oh, I'm sorry. Do you realize you're licking your fingers between each page?" She goes, "Oh my God, you're right. Oh, I got to stop that." And she did stop it for about 3 minutes, and then she proceeded to lick her fingers again. Now, I don't know if that's a psychological readiness, but maybe she needs to put something disgusting on her fingers. Maybe she probably already has something disgusting on it, but like some bad tasting thing or something. All right, what do we got there, Dawn?
So we also have getting buy-in for need for improvement in hand hygiene. So getting that that buy-in from most that this is even something that we need to improve on.
Nailed it. Absolutely. I can imagine, I'm not saying that all doctors are arrogant, but I've certainly, when I became a doctor, I became arrogant. So I'm assuming it happens. Right. So you can say my hands aren't dirty. I just washed them. Like when I came out of the bathroom, I just washed them. Of course, you touched all the doorknobs, you touched the chart, you touched, Yeah. So getting buy-in for that this is important, that maybe there is a huge connection between hand washing and the spread of germs. The germ theory is true. This much, I don't know about you guys, but it seems to me that in our country right now, that it's not easy to get consensus on what is true about infectious disease, and I'll leave it at that. Anything else about psychological? Need of hygiene 101, yeah. Just basic.
Yeah, so that's a great point. Like if people don't know the basics, they may not know that there's a problem.
So true. It's very, very true.
But we might have to actually, back up where we start in terms of preparing a group, an organization for a change.
Yeah. I think of another story my wife told me. She was getting a shot, I think, and the woman put on gloves, and it was, she did everything right. And then she turned the TV off. And my wife said, "You're going to change those gloves, right?" And she's like, "What are you talking about?" I said, "You just turned the TV off." And she was all, irritated that, you think that touching the TV could spread, and it can. You can spread, a lot of pretty nasty stuff happens in the hospital. What's the glitter effect? Oh, right. Just like glitter. Nice. So, right. Who is B. Nelson? Because they seem to know what they're talking about. Yes, you can look at what people believe about hand washing and you can measure that over time. Yeah. And hand watching too, probably. All right, really good. Right, and I like Melissa's point about the glitter effect. Do you remember I don't know if you had this in elementary school where you were given like a dye that you put on your teeth and it taught you to brush your teeth better, that you couldn't get the red. Did anybody else do that? Is that just me?
Yep, we did that, Tom.
Okay. I'm wondering, like, what the heck did I put in my mouth? All right. So I think you're getting the idea. So returning to this idea of implementation science, the problem in the early days of a new field like this is that everybody has a new theory and the thing just explodes like a supernova, often before anything is really tested well and we get to the bottom of things. And I think that's true in clinical supervision, which is why I endeavored to put together a best practice synthesis. So we try to take the best stuff from every theory and model and put something usable together. So right now there was an article that came out and it identified 61 frameworks, models, and theories. And apparently there are differences between frameworks and models and theories, but that's a lot. Then they had another article with 76 strategies to address various determinants of practice. And determinants are just like the reasons that will prevent us from changing the things that, here it says, determinants mean what is keeping or determining the status quo, what will kill the change effort. So this is not going to be helpful for us. We can't deal with 61 models and that kind of. And so I tried to find some of the most simple of the models, and EPIS is very simple. And what EPIS is just an acronym that means we're going to do exploration about what it is we need to try to change. Then we're going to prepare for that change. Then we're going to do an implementation, and then we're going to work on sustaining that implementation. And so the exploration has been going on for a long time, and the leaderships of the hospital and at the Department of Health have identified psychosocial interventions as a critical part of the mission of our organization and a place we could we could really focus on to try to improve clinical outcomes within the system for reasons that I've been talking about over the last couple of days. The preparation is what we'll do today, at least we're going to do this in an ongoing way, but we're going to do something called implementation mapping, which is where you talk to the stakeholders about what do they think are the issues and is it feasible? And oh, I didn't realize that was you. It's Beverly. Oh, excellent. Thank you. I'm sorry. I'm looking at the chat. Beverly's. I know Beverly actually. Okay. And as we do the implementation mapping, which is the idea of asking stakeholders, what are their concerns? What do you think the strengths and weaknesses of the project are? Then we're going to set about to very slowly and gently implement strategies to improve clinical outcomes and support staff, which is the two goals of this clinical formulary project. And then, of course, sustainment is we stay on it and we keep asking stakeholders their opinions. All right, so I was using the example of motivational interviewing, but kind of got ahead of myself. All right, so the planning then, implementation mapping, a systematic process for identifying barriers, improving readiness. I think it was Chris Morrison who first used the term pre-morbid. So you heard of a post-mortem. I think there's a pre-mortem or a pre-morbid, which just means, I think there's a cool slide coming up. Is it coming? I lost it. That's coming up later. It's very cool. But it's just what's going to kill this project. And we might not be able to determine right away. We might have to step in it to find out. But it would be really helpful if we ask people what they think. What are the dangers? So this is that woman, Carol Lewis, who is a heavy hitter in the field of implementation mapping. She wrote this article in 2018. And she said that implementation mapping has 5 steps. And it really has to do with surveying or doing focus groups with stakeholders. And today we're going to do we're going to try to do what is essentially a focus group with you guys on your concerns about this project going forward. And we'll try and compile, and we already have a list of barriers, but we're going to try and add to that list based on you. Then we'll go from there to develop a plan. All right, so these are just examples of the structural and psychological for the MI example. I'm not going to belabor that. Now, one of the things we learned in trying to use implementation mapping was this idea of an SEM. And for whatever reason at Rutgers, people doing their PhD dissertations have been using this a lot. And it just means, socio-ecological model, but it really is this kind of concentric circles where you look at an organization and you see the levels of the organization and the segmentation of the organization. And I would say our hospitals have not only these concentric circles, but they have pizza pie cuts for the disciplines, right, are different, and the complexes and the units. And I would argue that our system is extremely highly segmented, meaning there are small groups and those groups can form subcultures. I think direct care staff have a subculture, psychology has a subculture, social work has, and on and on and on. So why am I telling you this? So if we're doing implementation mapping, we have to hit as many of these segments as we can. We've been doing this work for a while now, and we found that the concerns about this project were different between hospitals. That makes sense. They were different between, the CEOs had different concern than the supervisors had different concern than the facilitators of the groups. And we haven't gotten to the clients so much yet, but I'm sure they have different concerns and important, and they're all legitimate concerns, which is, I think, very interesting. All right, let's skip that. So what I'm going to do now is just very briefly go over what is this project, because I blew through it at the beginning, and I'm going to go over it again. So we'll go through it step by step. So the first step are identify the list of core programs. So the question I'm going to put to you guys coming up is, are these the right programs? Or are there other programs? and should we get rid of some or add some? A legitimate question for you. The reason there's illness that those two are in highlighted is because they can be combined. The supervisions can be combined for those two. They have been in the past, and it works fine. They're so similar, vocational IMR and illness and IMR. And also, I don't know if you know these programs, but NJHMR and MDLE are very similar as well. And we have done the same supervision for both. All right, so that's step one. Step two, train staff in a highly restorative form of clinical supervision. That's what you've just suffered through the last 3 days. And the question here is, what else can we do to support staff, supervisors, to do this kind of work? Step three, and obviously the font keeps changing because I just put this in before the training. Start supervisor supervision. So, and this happens one time a month, and we call it meta clinical supervision, or MCS. And the mission of this is to promote best practice clinical supervision, I'm reading it, by replicating the use of these best practices at the supervisory level. Supervisors of promising best and evidence-based practices support each other to oversee high fidelity, effective interventions for the benefit of patients. Okay, so I'll break this down. We're going to use best practice clinical supervision in the supervision for the supervisors so that they can get more comfortable with it. That's what meta-clinical supervision is about. But it's also super duper supportive. So how does it differ from what I'll be calling intervention-specific clinical supervision? I think it's way more fun. It only happens once a month. The goal is to improve supervisory skills. I've already said it's super restorative. And we don't focus so much on clinical concerns as we do on supervisory concerns. That's the main content difference. So I don't know if you're getting this, but this is a supervision for the supervisors within the hospital that do the various projects. So you would, if you're doing IMR, if you're supervising IMR, you'd be sitting next to the person supervising TFMO and sitting next to the person supervising readiness check-in, that kind of, that's how it's supposed to work. Now, this supervision is ideally peer run, right? So it rotates facilitation. We don't have to start it that way. We do have the opportunity. I'm going to show you something here. Dawn, are you seeing the table?
Yes.
Okay, so here's a list of all the programs, the 8 programs on the left. And here's who's been identified. Some of you are on this list already and you're in this training, but everyone here, for the most part, has attended this training, suffered through this training previously. But the column on the far right are people working for Rutgers, and these folks are available as technical assistance people for the supervisors. And what that means is they can help with fidelity assessment, they can help with supporting you to get started in the supervision. They can really there to help with whatever they can. What am I missing? Anything about the role of faculty, Dawn?
Also to provide training as needed. You know, either they might be like mini trainings within supervision. We can attend those, or to, you know, once a supervisor or a set of supervisors might identify some training issues, then we can arrange that. It's a good conduit that way as well to training.
Good point. And so I know it's complicated, but so there are 2 levels of supervision. There's the meta clinical supervision for supervisors that happens one time a month. And the faculty can help support that. And particularly because it's peer run, it can, you know, if nobody steps up to kind of organize it, it can get floppy. Now, but keep in mind, the technical assistance people from Rutgers are not running this show. This is a hospital show, and it's your show. We're there just for support. So this is not a Rutgers project. It's a, you know, the hospitals and DOH commissioned this, and we're here to help if we can. All right. So that is, oops. So it kind of looks like this. There's different models, but here's just 4 of the practices. But So meta supervision happens at the hospital level 1 time a month, and the supervisors from each of the 8 programs attend that meta supervision. And I'll tell you what, at Trenton, I'm in it, and it's one of the best experiences of my professional career. Like, I really value it. And I hear the same from the supervisors, and they have no reason to lie to me. Well, maybe they do have reason to lie about it. I don't think they are. Oh, they actually offered, many of those supervisors offered to come to another hospital and just talk about what they get out of it, because they like it. Now, the other important thing to note about that is, for the most part, and almost in all cases, your boss is not in that meeting. So if you're a rehab supervisor, the director of rehab is not in that meta meeting. If you're a social worker, the head of social work is not in that meeting. It's really a restorative meeting for peers, supervisor peers is the goal. So, we might break that rule at some point, but I'm not aware of it at this point. All right. So let's look at step 4. This is the other level of supervision. This is the intervention-specific clinical supervision. I know it's complicated. And this happens 2 times a month at minimum. Some sites do it every week, particularly the trauma programming, because it's pretty intense, that work. So it's every other week. And this is the supervision, for the most part, you've been learning about, although there's very similar to both types, where the focus is on the mechanism of action of your practice. And this is like all people providing IMR would go to an IMR supervision. That's what this is. Or all people doing TFMO would go to TFMO. So why 2 times a month, you ask? Well, we've done this for years, and whenever we've dropped to 1 time a month, it kind of fell apart. It just didn't seem enough to build a cohesive group, or for people to really feel like it's being supportive in the way they need it. Ideally, I would do it every week, but I would be shot. People would kill me if I tried to make that happen. And ideally, this is where we would be using audit and feedback. So the supervisor of IMR would periodically review, would sit in on groups and give people feedback using the scales we have available. We have a clinical fidelity scale for each practice. But I recognize that's very difficult. And so we'll talk about the options. And one of the saving graces of this approach is that you'll be supervising a clinical program, not the person. So you're supervising illness management and recovery, not Fred, if that makes sense. And the reason that's important is the various clinical groups have standards for clinical supervision where they can, you have to be supervised by a this or a that. And there may be union concerns. And so in this way, the supervisor is supervising the program, not the clinician. All right, step 5. Did I have the numbers right? Yep, step 4, step 5. And here's where it gets complicated. We've been asked to improve the clinical quality of those 8 programs to the best we can. And there are pockets of absolute excellence right now. And so it's not like we're in, we're starting from the ground zero. So we want to look at the programs in terms of fidelity to the program. In other words, are we delivering it the way it's been shown to work and produce good outcomes? And is it producing good outcomes? And so here are the 3 levels of measurement that we're going to undertake. The first is structural group fidelity, and I'm going to show you that scale in just a second. But it is what it sounds like. Does the person have what they need to provide the program? Do they have a confidential space? Are the people in the program, do they meet the inclusionary criteria and not meet the exclusionary criteria? That kind of thing. And this is done in every supervision. And the reason it can be done, it's self-report by the person doing the group. And it's 4 questions. And it's done online. And I'm going to show you in a second. Okay. The clinical group fidelity, this is the hard part. This is where the supervisor, ideally the supervisor sits in on groups. And we're shooting for a minimum of 2 times a year that they sit on the groups. if we can't do this, there are peer methods available, as I mentioned in the previous trainings, where peers can evaluate one another. But we really want to be doing some kind of clinical group fidelity where, if you remember the social skills checklist, you're just taking that checklist and like, did they do these 12 steps? And it's really pretty basic stuff. It's not rocket science, unless you're doing a rocket science group, and then it is rocket science. Okay. And then lastly, we're going to be looking at outcomes. And generally, this is 6 months to a year. It's just so difficult to do it in our system. And oftentimes, we're doing it archivally. Like we look at, are we reducing readmission with the program of IMR? And we can determine that based on the group schedulers and readmission data. But some programs do have pre and post tests. And if you know your program really well, you'll know if you may know how your outcome is determined, or how a outcome. All right, let me just see if it looks like this is going to be linkable. So let's just look at the supervision fidelity. This would be done every, oh, I'm sorry, this is group structural fidelity. Let's look at this one first. This is the, I'm going to move it over when it comes up. Dawn, are you seeing the red cap survey?
Yes.
Okay, so here's the structural group fidelity. So every time somebody goes to the intervention specific supervision, anybody who's doing, say, IMR, and here's the list of groups right here, they would just, on any device, could be their phone if you're comfortable with that, or they could, prior to the meeting, they could go on a laptop or whatever. I think most people have smartphones if they're willing to use them, it's fine. So you could be sitting in the meeting and you go to this link that I just clicked, which will, if you're on a Zoom meeting, which I think many of these supervisions are going to be done via Teams or Zoom, you can just click it on there and do it. What hospital you're from, what program are you doing? And here's the 4 questions. And I apologize for the double numbering, I'll fix that. And the first question is the environment adequate for the program? i.e., you have enough space, privacy, lighting, noise, etc. Yes or no? Do the participants meet inclusionary and exclusionary? Yep. Did it start on time? Yep. Was the group canceled? And I think we're going to add a note thing, like if you want to put some other issue. So you say, why is this important? It's important because so many times the quality of the group is so affected by the patients not getting there on time. Like they just don't get an escort, or you have no confidentiality. You're trying to do the group in the middle of the day room because of COVID, and it's just terrible. All right, so that's that. Any questions on that? Anybody want to ask a quick question on the, let's click this. Okay, one other thing we have, and I kind of forget the frequency of this. I think this is monthly, and we'll cue you when this is due. But this is another survey, and this just asks about the supervision, because we know that if the supervision is highly restorative, staff should really like it and get a lot out of it. And so did we follow the structured agenda? We'll give you a generic version of that. The thing where the meeting was held, I attended both meetings this month because there's supposed to be 2 a month at least. I was observed delivering programs. You probably not, but maybe you were. Minutes were taken. We focus on staff self-care, team building, resilience, or other restorative exercise. And so you can see the idea is, is the supervision you getting yelled at, or do you feel supported? And now this will undoubtedly get better as we do this, as we learn more. But this is kind of the start. All right. So here's that cool slide. It's in the wrong place, but pre-mortem is just what's going to kill us. Here's the steps of implementation mapping. All right, so now I just want to take a few, and we're just going to do this for about 15 minutes, where we're going to look at these questions. Dawn, can you oh, you can't copy them. God, I hate this. If I send this to you, Dawn, could you copy it and show our people? Because it does, the chat doesn't go with.
Copy it, you mean put it into my breakout room?
Yeah.
Or what?
Yep. Your
Okay,
chat.
yeah.
Yeah. So basically, we're going to look at the 6 steps of the project. And if we have trouble getting you the specific questions, the big question is, what are your concerns about this project? And what are your recommended solutions to whatever the concern is, right? Because we want to move ahead, but we don't want to kill anyone. Oh, I should mention the time frame for this is over the next year or 2. Right? So we're not doing this tomorrow. And for once, I think we're, and maybe COVID helped with this, but we're going to kind of take our time and try and do it right and do it long-term right. All right. So I'm going to put you guys in breakout rooms. So we're going to do 2. And Dawn is going to be in 1. And I now figured out how to. Okay, so we're going to do this for 15 minutes, and we're going to come back at 2:15, and then we're going to debrief, and then we're getting out of here. Then we're off to the beach. So you've almost lived through this agonizing process. All right, so remember. So I'll send you the breakout rooms now, and see you in a bit. Oops. Hi, Shmarudi. Breakout room.
Everybody else in meeting.
All right. Wow, you guys came with me, it looks like. Huh, I don't even know what happened. Do-do-do. What are we doing here? Yep, there's Schmurdy. We're waiting for J.M. McAllister stuck in the room. And so is Adrian. I don't know why. What's going to close in 14 seconds? Ten seconds. There's Adrian. Okay, everybody's back. Thank you for doing that. That process of implementation mapping, we're going to keep doing it, and it's nothing more really than asking people at different stakeholders what they think would help and what are their concerns. So Dawn, what and really anybody from the group that I was not in, what were some of the concerns raised in your group, Dawn?
Sorry, you got me with some chocolate in my mouth.
Self-care there. That's good.
Yeah, a little self-care. So I would say probably the resounding message that folks were communicating was that there needs to be the time made available for all levels of those involved with this initiative, in terms of the clinical supervision as it relates to the recovery formulary, to be able to actually do this. Otherwise, this is unrealistic. Several people also noted that it's important that we assess to determine whether or not the folks who are supervising these practices actually have enough knowledge of each of the interventions that is in that, you know, they would be supervising in the clinical formulary. Because just because you are a supervisor does not necessarily mean that you've ran an IMR group, right? Or a TFMO group. So making sure that people actually feel comfortable and that there's a way of assessing, you know, really the competence at that level.
That's great. Yeah.
But predominantly it was the human and time kind of resource issue.
Yeah, I think for my group, and jump in anybody, it was the same thing. Jackie Frazier said, we got to give the supervisors the time to do this because it really is 3 hours a month. There's the hour for meta supervision and then the 2 hours for the intervention specific clinical supervision.
Tom, could I mention one more thing before I forget? Because a just second piece of chocolate brought it to mind. Ivy Durant suggested that we need to make sure that we allow the clinical supervisors to clinically supervise and we be able to tap on the QA departments for support in the outcomes and all that. So I didn't want to let that get lost. And I did say that's something we've been advocating for as well.
That's interesting because we had I won't call them out, but we had somebody in our group mention the same thing. Like the data collection can be super burdensome, and if you don't have clerical staff to do it, that would be a big problem. So pulling on QA and maybe changing their focus a little bit to look at clinical outcomes, which would seem like an important outcome for the systems, you know, that's good. So my group identified the time and the recommendation was that we go slowly into this over the next year or two, and that we don't have a start date that, you know, a hard start date where everybody's supposed to just jump in and do it. The other concern was that patients aren't ready to do these clinical programs because they've been, you know, it's been such a different world with COVID. And then the observation was made that's true of staff as well, right? I think we're all still in shock about, you know, the COVID and whatnot. One other recommendation was that data gathering, that Rutgers can help with that. We have some resources we can bring to bear to help collect data and fidelity assessments. And I think that's pretty much it. So anything else? Any other concerns about this project we can speak about as a group? I just put this up so that I can So there is a training evaluation, which I think I can put in the chat. Yes. I can only paste. Anyway, I'm going to put this in the chat, and I'm try to put this in the chat. And I encourage you to fill this out. Huh. It's just killing me. Does this ever happen to anyone? You can do nothing but paste. Yep. Yep. John, can you help me? Or maybe here and I'll do this. So I appreciate everybody participating, and hopefully going forward, we can make sure people have cameras, and because it's really it's very difficult, as you might imagine, to do a training like this, and if people want to participate more, or maybe they don't want to participate more, and we would like them to.
So I posted the training evaluation link in the chat, so you should be able to click on that.
You're so good. I don't know what I would do without you. We would not be evaluated. So, all right, guys. Well, that's it for this training series. Uncharacteristically, I don't think we killed anyone this cycle, so that's always a plus. And I really appreciate you participating. Any take-home thoughts before we sign off? Anybody learn anything from the clinical supervision training? Yeah, I see the link. Yeah, works. So before you go, one final question. What are the 3 functions in clinical supervision, virtually all models of clinical supervision? What are the 3 functions? Three functions. What are the 3 functions? Post-test. Whoop, whoop. Nice. And you did them backwards, which is awesome. And what would you say is the most important function? Melissa, you get triple stars. Triple stars. So arguably, the most important function is the restorative function, right? So I want you to take care of yourself and have a terrific weekend if I don't see you guys. And we'll sign off. We'll leave it here. Thank you so much. Great crowd.